Hi, everyone. Thank you for joining us today. I'm just going to wait for a few more people to log in before we get started this afternoon. I'll just give it a couple more minutes. Right, I may just get started now as the numbers have sort of frozen in terms of people joining us. So welcome to this afternoon's virtual information seminar on Duchenne muscular dystrophy. I'm Neeru Nayak, Deputy Director of Care Campaigns and Support, and we've got a very packed agenda this afternoon with a fantastic array of speakers. We're going to split the session into two parts, beginning with a discussion on the clinical trial process and a chance to ask any questions you may have on that topic. We'll then move on to a discussion living with Duchenne muscular dystrophy from a paediatric perspective, where we'll have a general discussion and focus on answering your questions, as well as covering any questions that we can that have been submitted in advance. We'll be using the Q&A function, which you should be able to see at the bottom of your screen. So please type in your questions or comments and we will feed them into the discussion. And please do bear in mind, if we can't answer your questions live, we will come back to you after the seminar to answer your questions. To help us manage the technical side of the event, we won't be calling on questionnaires to ask their questions directly. Any questions, like I say, we don't manage to cover or don't know the answer to, we will look into and get back to you following the seminar and answer them through our website as well afterwards. So before we begin, just a note that our helpline is available to anyone who's affected by muscle wasting conditions. So please contact us if you have any questions or are in need of support. We can help with information and can either support you directly or point you in the direction to an expert that can provide you with that support. So the number and email address should be on your screens, but I will just call it out in case. So you can call us on 0800 652 6352, or you can email us at info@musculardystrophyuk.org. And just a final reminder that this session will be recorded and it will be made available over the next week or so. So my colleague, Dr. John Copier, will be chairing the first part of today's session. And to start us off this afternoon, John will introduce one of our first speakers. So over to you, John.
Thank you, Neeru. It's my pleasure to introduce Dr. Vasantha Gowda, who's our speaker today in the first session. Dr. Gowda is a paediatric consultant and is the neuromuscular service leader at Evelina London Children's Hospital. She's an honorary senior lecturer at King's College London, where she served as lead for the postgraduate medical education for paediatric neurosciences for the last 5 years. She leads the nursing delivery service at Evelina, which is one of the 4 centres designated by NHS England for gene therapy treatment in children with spinal muscular atrophy. Dr. Gowda has been involved in a number of clinical studies in Duchenne muscular dystrophy at Evelina. Her talk today will focus principally on clinical trial processes. We understand that people may have interests in specific details of clinical trials in Duchenne. If we can't answer your questions today, as Neeru said earlier, we will endeavour to do so by email later. So without further ado, welcome Dr. Gowda. Please start your talk when you're ready.
Thank you for the kind introduction. Let me start by trying to share the screen. Can you all see this?
We can see it. It's not on presentation mode, but we can see it.
Now?
Yeah, perfect. Thank you.
Let me minimize all the, sorry, 1 second. Okay. Welcome to the talk. These are my disclosures. I just wanted to reiterate again that today's talk is not about the details of clinical trials that are happening in the DMD world, or the trial centers, or just in general, not about specific clinical trials. This is more about what participating in a clinical trial means to a family or a boy or a man affected by DMD. So we all know that clinical trials are very important in evaluating the effectiveness of whether their medicines, devices, services, or interventions to either identify, prevent, or treat the illnesses or conditions. I want to reassure you that I'm not going to go through all the subtopics listed here, but I just wanted to put this slide up here because these are all the steps involved in setting up a CTIMP, which is clinical trial of an investigational medicinal product, which is mainly drug trial. So this is a simplified version of the stages involved in a trial going live. The reason I have put this up is because this gives you an idea of what has happened before you hear about a trial going live. Those steps that you saw in the previous slide would have happened before a trial goes live. So you can see the kind of investment of resources and the infrastructure needed before the trial can go live. And therefore, most centers, most clinical trial centers would have identified some patients, a few patients at least, before they have agreed to take part in a study, or they would have agreed, they would have identified a process to identify patients at least before agreeing to take part in a trial. So sometimes there may not be patients at a particular site, in which case the PIC sites can help. These are the participant identification centers, which can feed patients to a trial center. Many times it could just be referrals from other tertiary neuromuscular centers or even secondary centers within the catchment of a tertiary center. And sometimes the trial centers reach out to other centers, asking for patient referrals and letting them know that we are now open for recruitment. And you also have the DMD registry by Action Duchenne, and also the new central patient database for DMD run by the DMD Hub. So what happens when all these patients have been identified and the trial centers notified? Then they have to decide who goes for screening, and they try to be fair and randomize the selection of patients for screening as well, not just for the placebo and the drug, but even for selection. You have to bear in mind they may have to prioritize the patients who had been previously identified. Sometimes they don't, sometimes they randomize the whole selection. It's also not guaranteed that everyone selected will pass through the screening. So there will be opportunities for others to take part at a later stage as well. So just a few things. You hear about phase 1, phase 2, phase 3, and so on. So phase 1 studies are first-in-human studies. Until then, they would have been preclinical studies, for example, animal studies. And the phase 1 studies look at the safety and the side effects of the drug to be tested. And the phase 2 studies look at the effectiveness of the drug. And the phase 3 studies are larger trials to look at the safety and effectiveness of the drug in more diverse groups and for longer periods. They generally run for a year or more. And the open label extensions happen after a potential benefit of the drug has been seen in phase 2 or 3 to determine long-term efficacy and tolerability and safety. For the open label extension studies, the participants from both the trial arm as well as the placebo arm are enrolled. So everyone gets a chance to get the drug. Phase 4 happens after regulatory approvals. So the real world experiences are, Jackie, you have your hand raised?
No, sorry, that was an accident.
Oh, don't worry. So phase 4 happens after regulatory approvals, and this is collation of the real world experiences for long-term risks and benefit data and potential rarer side effects to be watched out for. I also want to point out a couple of things about the clinical service and the clinical research. From the patient perspective or the family perspective, it seems such a simple thing. For example, if you're at a clinical trial center to get something else done whilst you're there for, you may be there for 2 days, 3 days, or staying overnight, awaiting something the next morning. And the trial center may say no to such requests. The responsibilities here are the clinical service center continues to provide the clinical service and care. For example, they do the DMD surveillance, adhering to the standards of care and so on. And the clinical trial center has to stick to a pre-agreed schedule of events which have all been costed for and a contract put in place. For example, if we receive a request for an echo for a patient taking part in a study, but not actually from our center, that would be difficult to offer at the center, because one, it's not part of the actual study. Two, just because the trial center has capacity for the components agreed within the trial, it doesn't mean that the cardiology service at that center will have the capacity to absorb more requests from outside the catchment. And also, whoever does offer anything will have a responsibility to act on any abnormalities, arrange future surveillance, and so on. They do remain. It is important that they do remain as 2 separate arms, and particularly, if there are trial-related questions years later, the trial center would be able to address this, whereas the clinical center may not. Sometimes you may have both at the same center, and it may be different consultants at the same center. Again, they may retain responsibility for clinical service, and the other person may retain responsibility for the clinical study. But sometimes it may be the same person doing both. That's when there's a bit of confusion as to this person did everything, why is the other person not doing everything? It is important to have clear communication between both sides for all matters. Sorry, one thing to say, for example, if some procedures have been done, for example, someone's had a MRI or a DEXA scan as a part of the study, it is entirely reasonable for the clinical service to consider that a part of the standards of care and sort of not duplicate the same thing. What else? You are all aware about the randomization. It could be 1-to-1. One person gets the placebo, one person gets the drug, but generally it tends to be a bit better than that. 2-to-1 or 3-to-1. So 2 and 3 being the drug and the 1 being the placebo. From a participant perspective, you need a clear point of contact for all study-related matters, for not just 9 to 5, what if you have a question out of hours, who do you ring, what do you do, and so on. you need to know what to do in the event of any, sort of significant adverse events or side effects. In general, these involve a trip to the local hospital who have a role in stabilizing the patient and then sending them wherever they're meant to go, wherever is the best place for them. It doesn't always involve a trip to the trial center directly, but you need to know what to do and you have a clear plan for whatever concerns may arise. Sometimes these are trial related, sometimes these are not trial related, but it's difficult to know at that stage, which is why you need the plan. Very rarely, in a blinded trial, there may be a need for unblinding because of the side effects that would be discussed with you, and proper procedure adhered to. I also just wanted to mention the ethical side of testing new drugs. You may hear some trials stipulating that the patient should have been on a stable dose of prednisolone or a steroid for 3 months or 6 months or similar. So why does it happen? It's easy to explain this by using an example of an epilepsy drug trial. Nowadays, the ethical committees do not approve of a new drug therapy versus placebo when there are drugs with proven efficacy available for a particular condition, because being treated with placebo means that they may be exposed to a greater risk of morbidity or even mortality. And therefore, if there is a new drug treatment for epilepsy to be tested, what generally happens is they recruit patients who are already on treatment but are still having sort of more seizures, what we can consider refractory epilepsy, and the new drug is added on to whatever the current or the prevailing treatment is, and then compared against a placebo with whatever the prevailing treatment is. And then once it's proven its efficacy, it could be trialed differently later. And hence you may see the stipulation about the stable dose of steroids. It's also important from another perspective. You don't want the dose to be changing, because if you're changing the dose and then enrolling into a study soon after, if there are changes in outcome measures, you wouldn't know what affected it, and hence the need for stability for a period at least. I mentioned this earlier. It is important to have clear communication between the clinical care centers and the clinical research centers, and also the district general hospitals and the the GPs and whoever's involved with the patient care. We are all guilty of this at the trial centers. We may send the letters out to the GP, but may not always copy all the other people involved. It is important because if they have a query and they're not aware that a child is participating in a clinical trial somewhere, then they, the decision they make may not be the right one, as they wouldn't have taken into consideration everything. Mostly, it doesn't matter as much, but it's still important to share this with all clinical teams involved in the care of a child or a patient taking part in the study. You should also ask for details of any compensation that the sponsor would be providing, any reimbursements for accommodation or travel this entails. Some of the studies go on for a long time, and the exon skipping studies of a few years ago involved trips to the hospital every single week, and for many overnight stay, and sometimes it could be more than once, because there had to be bloods done repeated and so on. So all these add up. So you need to know exactly what the reimbursement arrangements are, and so on. Other things to bear in mind, you don't hear about this, but throughout the duration of the study, the data safety monitoring boards attached to the studies are monitoring the safety data constantly, particularly in the early phase studies. There could be pre-agreed stages in the study when they would be analyzing the interim data, and this may influence which direction the study takes after. And there are usually clearer criteria when the study stops and for what reason and so on. If it stops before the scheduled closure of the study, if there's any need for premature stopping of this, it could be any reason such as not meeting the outcome measures in the interim analysis, or significant side effects, lack of funding, or falling foul of some regulation aspect of it. So there could be many reasons. There are some specific issues around the CTIMS or clinical trials in the DMD. We all know that there are some exon skipping studies, and only some patients can participate in them. This is because this is such a heterogeneous group with deletion of a combination of exons, or duplication of a combination of exons, which is quite variable, nonsense mutation, missense mutation, and so on. And there are varying clinical phenotypes as well. Some boys may be physically more able than others, but more importantly, some boys may have significant behavioral difficulties, which means every single time that the trial demands a MRI, for example, cardiac MRI scan or a DEXA scan or something else, where they have to lie still for a 15-20 minute period or even longer, those who have behavioral difficulties are automatically excluded because they wouldn't be able to cope with that. So there are several aspects of DMD which influence participation in a trial. And there are different angles of approach to management of DMD. We know that there are exon skipping studies. There are studies looking at steroid analogs, the gene therapies, the anti-myostatin products, HDAC inhibitor products, and so on. Before enrolling into the study, I mean, as PIs, we do ask and sort of try and pin this down before we agree to any studies. But it's important from the participant perspective as well to know what the sponsors are planning after the ending of the study. After it concludes, are they offering an open label extension, or are they just applying for approval, to a regulatory body? Exactly what's going to happen after the conclusion of the study. Sometimes some sponsors could arrange post-trial access to drugs. For example, they may call it extended access program, or they are using the term loosely, the compassionate basis, but it's not quite compassionate basis. This is just the interim arrangement for the sponsor to provide the drugs, or provide access to the intervention or the drug whilst waiting for regulatory approvals. This is quite a complex issue, because nowadays it's not just providing a pill that can be taken orally or through the peg at home. Quite a few of these involve intravenous access, intrathecal administration, and so on. So there is a huge additional cost to providing access to the drug, and it's not just the drug, so it could be quite complicated. This is evolving as we speak, so we need to see what the future trials will offer. This is the last bit, and I wanted to touch base on this. So I put the references there. So despite significant efforts to improve each aspect of the drug development process over the last several decades, the success rate of drug development remains at 10 to 15%. What does it mean? That means that only 1 in 10 new clinical trial for a drug succeeds. So 9 out of 10 fail. And it's important to bear that in mind. The first time I was a PI, and I'd invested heart and soul into that. So had my patients who were participating and the entire study team. And when it was pulled abruptly, it has to happen abruptly, I'll come back to that, because of not meeting the outcome measures in the interim analysis. It was a shock to everyone, despite anticipating, not anticipating, but despite being aware that 9 out of 10 studies tend to fail. So what happens when this happens? The participants and the families will be notified by the trial center, but more often than not, they hear about the trial cessation in news on social media at the same time as the trial centers do. So they would still be contacted by the trial center, updated, and any queries addressed. Usually they'll be offered counseling too. And on top of the shock of this, there will still be a few visits required to tie up loose ends, because they have to happen to conclude the study safely on most occasions. So it is important to adhere to that as well. I mentioned the sudden stopping of the trials. When I was brand new to conducting the clinical trials, I had wondered why we couldn't be, why the trial sites couldn't be informed sooner, so that we are mentally prepared and could help the families better. This is all to do with the financial regulation, where the stocks and shares could be shortchanged, etc., and hence the announcement has to go to the entire world at the same time point, and hence this will be the situation for any premature cessation of any trial. I shall stop here, and I'm very happy to take any questions.
Thank you ever so much for that talk. Very interesting, I think, not just actually for our audience of people living with Duchenne, but also for anybody who has any other neuromuscular condition. The clinical trial process, as you've outlined, is extremely complicated, and I think it's really good for our audience to hear that. Just for the people out in the audience, we can't take questions, audio questions. So if you have questions, please put them in the Q&A, and we'll try and manage those. Somebody has put a question to us through email. I'll read it out. It may be a little specific, but I'd like to kind of broaden that out a little once I've read the question out. So NICE recently made a decision not to approve valmorolone based on cost effectiveness. Could a compromise be made whereby boys did alternative years with valmorolone and conventional steroids in order to gain some benefits and reduce costs? Now, we're going to respond to that by email. The final decision from NICE on valmorolone, I think, is not yet made, and there's a further meeting to come. But if you feel able to respond to that, that would be great. But perhaps also explain a little bit about what happens beyond phase 4 and how the NICE decision kind of integrates into how drugs then find their way into the NHS. That would be very helpful.
I think that is a very complex situation to have one drug 1 year and the other the next. Switching, there are still discussions happening about switching from steroids to valmorolone and how to do it safely across different age groups and various different groups. And when we are still exploring that, I think it would be very difficult to comment on switching back and forth constantly. But as we usually see this happening with other drugs, even in the sort of adult community out there with other conditions. whenever this happens, there tends to be a bit of back and forth between the sponsor and the NICE, and eventually, usually a compromise is worked out. So we have to watch the space and see what happens.
Excellent, thank you very much. We have another question here. Is it possible to receive an exon skipping treatment after gene therapy? As I was reading this question, it occurred to me that our audience often asks questions about why they can't be included in a particular trial. And I think you touched a little on inclusion exclusion criteria, but perhaps also expand a little on that and why everybody can't just be included into any one trial.
Right. So I shall. I wish I had the. Is it okay if I bring something up and share it? That may be a bit easier to just. Let me just get the.
Well,
sorry, I hope I'm okay. I can't find the dystrophin gene picture that are on my desktop, but I shall try to answer this without the picture. Let's see if I can just oh, okay, I might just find one here. Oh yeah, it is here. It's not a great thing, but I shall share this and try and work through that. Share screen. Okay, this one. So can you see this now?
Yeah.
Okay. So when they say exon, this is a random sort of picture I have found online because I can't find my own. So when they say, for example, exon 51 skipping studies, what they mean is they are using something that makes the exon 51 not detectable for the reading frame to produce a dystrophin protein. So it isn't quite exactly as it has laid out here. It's not the shapes that fit, but just imagine that they have shapes. They actually have chemical configurations that fit. But if you consider them as shapes that are here, so if I have a patient who has DMD because their exon 50 is deleted, okay. So if you see the 49 cannot attach to 51, can it? Because the chemical configuration or the shape here don't allow this. But if, for example, in that patient who's missing this exon 50, what if you actually make the exon 51 not readable or skip it? Skip the exon 51. Then you can see that the 49 could actually attach itself to 52, and they may then produce a dystrophin which is slightly shorter but functional. So that is aim. But what if you try to do that with some other random exon or a few exons that are skipped? Not all of them would benefit by skipping one particular exon because they have to enable the adjacent ones to attach, whatever is left. For example, it could be my patient could have exon 43 to 50 missing, but if we skip the exon 51, the 42 can attach itself to 52. So there are various combinations that could be eligible for an exon skipping study. But one exon being skipped doesn't mean it would work for all the boys who have DMD because of different combinations of exons being deleted or duplicated. Okay, so and hence we say this is not some children are not eligible for particular exon skipping studies and such. So it's the same with the nonsense mutation. So it's a particular kind of mutation and hence, what works for them would not work for other types of mutations that we see. I'm sure people have heard that there are particular groups of exon deletions that Professor Montoni picked up, who were having a more severe, significantly more severe adverse event across all gene therapy trials. When they looked at all of them, they realized it was the same group of exons that the patients were missing, exon 8 and 9. So when it comes to further, tidying up the gene therapy process, then these patients would be excluded because it wouldn't be safe for them to receive that. So there are several, which is why I said the clinical trials in DMD is a bit more complex than many other conditions. They have a condition and that is it. But here, within the condition, there are so many different genotypes, phenotypes, situations. So, phenotype is usually more homogeneous, but there are differences in the genetic side, and hence it's difficult to offer the one clinical trial to all patients. Going back to the particular question about can someone who's participated in gene therapy, can they participate in exon skipping studies? Usually, when there is no contraindication, there's a definite washout period. They may say patients who had taken part in some other study, more than a year ago or 2 years ago or whatever, may be eligible. But if it's after gene therapy trial, we are talking about the trials here in the UK because nothing's been approved so far. I don't know of other sponsors who are right now saying that, because I think there will be some concerns about the long-term effect, because the gene therapy the study participants may warrant a much longer observation following the treatment. So I don't know whether we are at a stage where we can say it's been a year, so let's just enroll them into some other study. This is my opinion. So, but as things evolve, things will become clearer.
Completely, and I think you could carry on talking about inclusion, exclusion for another hour on its own. But I mean, I guess when it boils down to a combination of safety and whether it would be efficacious in that patient. We have a few more questions coming in.
Is it okay if I answer online and then someone can carry on with the, I know I'm holding everyone up.
No, I think this is.
Fine,
I think this is fine. We may not get to all of these questions, but certainly. So we have a question here, which I think is not just applicable within the Duchenne community, but certainly anybody with a rare mutation would be interested in the answer. So what's the likelihood of trials being developed for your child who has a rare genetic profile, e.g. a splice site variant?
A good question. So usually when it makes sense to the families as well as the companies who are financially invested that they tend to go for something that is more common than extremely rare. I mean, even in the rare diseases, it's generally the reason they chose the 51 exon for the first treatment is because they looked at the whole DMD community and realized if that is the exon that is skipped, they can then target a lot more people than, say, skipping another exon. And hence they started working on that first, and then they worked their way down the frequency of it. So it may be that with some of the rarer ones, they don't have as many studies or they don't have as much interest, but it doesn't mean it doesn't happen, because I'm moving out of the muscular dystrophy here. For example, AADC deficiency is so rare. And I think we didn't find a single patient in a year when we were looking for it. I was working with the company, but the studies were done at Great Ormond Street Hospital. But they do have a gene therapy. They have, I think, one more gene therapy in the pipeline. So they will have 2 gene therapies available. So It's not to say that there won't be anything, but these are driven by various different factors.
For sure. And I kind of my personal reflection on that, having just been to a translational research conference at UCL, is that a lot of the gene therapy and the specific genetic therapies for things like Duchenne will eventually be rolled out and will be used for other rare conditions. So I think there's possibly still hope for the future. I'm not going to put you on the spot very much longer. There's a question here. I'm not quite sure if the person out there wants to just clarify what they mean by advocate for a specific clinical trial. I'm interpreting this actually as more, how do people find clinical trials? I mean, we signpost out to clinicaltrials.gov when we answer questions within the research team. I understand that it can be quite difficult to find clinical trials for patients who just don't know. So do you have any recommendations in that regard?
You do signpost them, and I'm sure all the other charities do as well. And as clinicians, we constantly remind families and patients and parents to register their interest. I wonder whether they mean if they, that's what I was thinking. So if they are either thinking of setting up a particular study or, sort of gather more support for a particular kind of study, I think that is being done so well with all the patient advocacy groups. I have to say, in the neuromuscular world, they have been instrumental in bringing about, see change of how things are done. If you're looking at the standards of care for DMD or SMA or the clinical trials that are happening and the advocacy activity that is happening. So I think that would be the way forward, along with the sort of interested academic center to carry out this work. I've just seen the other comment too. Can I just say to answer that? So the question is, as Tracy's son is registered with DMD Hub, including provision of his molecular genetic report, has selected all the types of trial we are interested in. I understand that being registered isn't a guarantee of being contacted by a recruiting site. Sarepta Envision gene therapy trial, for example, Sarepta Envision gene therapy trial, and the recruiting sites, would these sites look to recruit from their own region first and only contact other hospitals for interested parties if recruit? I think it's a bit variable, but from what I understand, my own patients were sent elsewhere to participate. In fact, 2 sites were calling them both, calling the same patient, to both the centers. They, as I explained, they would have identified at least one patient for some of these studies. Otherwise, they would be setting a more than £1 million study at a center with no patients whatsoever. So they would have identified one, but they wouldn't have all the patients necessary. If they're aiming for 3 or 4 patients for rare conditions, then they might have to reach out to other centers. In fact, my patient was picked up through the DMD Hub patient database. So quite a lot of people are being approached. But if there are many, many patients, then they do select them randomly. So it's not as if someone is being prioritized over the others. It may be that the randomization means that not everyone gets a chance, but some do. And it's a bit fairer than choosing our own patients or someone we know.
Excellent, thank you very much. The comment here, how does a person influence the start of a trial, I take is a clarification of the earlier question.
Yeah.
I'm just going to ask this last question. We've put you on the spot for quite long enough, but this is definitely something that our audience is going to be interested in. So as a parent of a 5-year-old with a large deletion, I'm interested to know your opinion regarding how far away you think a successful gene therapy is.
I hope it's okay if I choose to answer this in you know, in a slightly different way than you expect me to, rather than explaining how far away I think a successful gene therapy is. I think it's important to remember what a gene therapy actually means. A gene therapy could mean you know, sort of almost complete normal life in a child born with SMA if given within the first week or when there's absolutely no symptoms. You have to bear in mind when they try to do the pre-symptomatic study in children with SMA for the gene therapy, a third of the patients failed the screening, although, you know, many were just under 2 weeks of age, because when they did the neurophysiologist testing, they were affected. So if you look at those who are truly not affected, the results have been amazing. Having said that, all those who are treated at 6 months, they are still in their, you know, wheelchairs, have significant morbidities. They require an IV, as many have assisted feeding, and so on and so forth. So what do we mean by gene therapy? Is the magic pill that we think it's going to be? Unlikely. You know, this is very unlikely. I think that this is purely personal opinion. A part of the problem with gene therapy with the SMA was, I feel, the very high expectation from the gene therapy. And people expected miracles from it. And when the miracles weren't delivered, they felt that it hadn't worked at all. And then they wanted, you know, sort of access to the other drugs, etc. There are various, you know, sort of variables and confounding factors there. It depends on the baseline of the child who was treated, then, you know, sort of the number of SMN2 copies and various different things. But coming back to the question, we need to know what we are, we need to understand what we are trying to achieve with any therapy. So is a gene therapy going to be better than vamorolone? Is a gene therapy going to be better than givinostat, for example? Is it going to be better than a combination? We need to see what we find. Some of the data has been promising. I know with the Sarepta, which will be delivered by Roche in the UK, they didn't meet the primary outcome measures, but the timed tests were, you know, sort of promising. They are there. I mean, we were not even here 4 or 5 years ago, but we are at a stage where there are many trials happening parallelly, various different safety profiles and, you know, efficacy profiles. But I feel that we are getting there. But going back to the question, that's not the only answer, I feel, and we need to look at everything that is available and tailor our expectations to what we want from this, and, you know, balance them against the risks as well.
Fantastic. Thank you for that answer. So for our audience, if you have further interest in knowing about research into muscle wasting and weakening conditions, you can always contact our research line. The details are on our website and also on the slide that occasionally gets put up. So it's time for me to bring this session to an end and to hand on to Neeru, who's going to chair the next session of Living Well. So thank you very much, Dr. Gowda.
Thank you.
Thank you, John. So we'll now move on to the discussion about living with Duchenne muscular dystrophy from a paediatric perspective. And I'm now going to be delighted to welcome 5 more panelists today who'll be joining Dr. Gowda and will help us discuss and answer your questions. So today we're going to be joined by Agnieszka Szmurlo, Helen Craney, Jennie Sheehan, Dr. Philip Davies, and Gerry McMenemey. I'll introduce each speaker and invite each of them to make a few remarks about their experience of supporting children living with Duchenne muscular dystrophy and their families, and to raise some key points about managing or living with the condition. As I've mentioned at the beginning of the seminar, we'll be covering as many questions as we can, and some of the ones that have been submitted in advance. We'll also be using, as John said, the Q&A function, which is at the bottom of your screen. So do start typing in your questions as and when they come up. And any questions we don't manage to answer, we'll answer directly after the seminar. So my first speaker I wanted to introduce was Agnieszka Szmurlo. Agnes is a specialist paediatric dietitian working in a neurosciences team at Great Ormond Street Hospital. Day to day, Agnes sees patients with neuromuscular conditions and children who require ketogenic diet for refractory epilepsy. Agnes works closely with neurologists and other healthcare professionals to support the unique needs of children with neurodisabilities and to improve their health outcomes through dietary management. So what I might do now, rather than listening to my voice continually and doing everybody's bio one by one, is hand over to Agnes just to make a few comments from her perspective.
Lovely. Thank you so much, Nira, for that introduction. So overall, as Nira mentioned, I just wanted to go over a few kind of key points for a dietitian and what a dietitian can do to help patients with Duchenne muscular dystrophy. So I think initially, first thing that we need to be aware as dietitians and clinicians is that patients with DMD are at risk of weight gain and weight loss at different times during the natural course of the condition. And even though these are complete, opposites, polar opposites, so excessive weight gain, severe weight loss, they might happen to one patient at different times. So overall, we'll just go quickly over some considerations and challenges, and then what a dietitian can do to help you. So overall considerations, challenges. The first quite frequently seen problem in the population with Duchenne muscular dystrophy will be weight gain. So we quite often see that in early life. And usually that happens with around the time when the loss of ambulation happens as well. And in a way, it's very easy to explain why we do see weight gain in patients. It is because of the mentioned loss of ambulation, but also quite often because of the side effects of using corticosteroids that are widely used in Duchenne muscular dystrophy. And I think in here, just wanted to make a remark that remember the loss of ambulation, the weight gain is not happening overnight. So it is a long process. So we need to be aware of that quite from the beginning when we have diagnosis. And then the polar opposite, weight loss, might happen at any stage, but usually we see that later in life, in teenage years, and when patients are approaching adulthood. I think most likely because of the continuous muscle wasting, and then we also start seeing some difficulties with eating and sometimes poor appetite, dysphagia, constipation that will then impact the appetite. So we do see weight loss often as well. Then I think for a dietitian, also for the family to understand that body composition of a patient is quite different to general population. We do have less of a muscle mass, more of a fat mass. So we as dietitians, whenever we assess growth, definitely need to be very aware of that. And then last thing, and I guess that is more maybe for dietitians, clinicians, and centers, difficulties with obtaining height. We really struggle to get a height for patients, quite often because of the patient not being ambulant, not being able to stand, to have their height measured because of scoliosis, and maybe quite often also because we just don't have the right equipment to check the height. So that is a shout out to all the centers and just to make sure that we do have the right equipment, because we as dietitians are obsessed with growth and we do want to see the height before assessing the patient. So how can we help? I think the most important thing to do is early intervention. So if you're a clinician, as soon as you start using steroids, as soon as you see any changes in weight, actually maybe as soon as you see the diagnosis, as soon as you have diagnosis, refer to your dietitian. And also do start discussing gastrostomy, alternative ways of feeding early on to prevent weight loss in the future. Then I think we also need more centers with dietitians. And remember, as a parent of a patient with Duchenne muscular dystrophy, you don't really need a specialist dietitian. You just need a dietitian to have this conversation about healthy diet to begin with. Alternative height measurements. We can use multiple different measurements to check the heights. So remember about that when you're assessing your patients. Sometimes maybe you're able to do the body composition rather than height, weight. So that is quite useful. And then last thing, growth charts versus growth curves. So basically, I think overall, we don't have Duchenne DMD specific growth charts just yet. But we just need to remember that whenever we're plotting heights, weights, we're plotting them on a general population growth chart. So just be mindful of that. And maybe instead of doing that, or together with doing that, let's go through research and find papers that are describing growth patterns. And I think, sorry, it was a long introduction. But yeah, I think these are my key points when it comes to a dietitian being involved with patients.
Thank you, Agnes, for your detailed contribution, and I'm sure a lot of it will be very helpful to the audience, and we may stem some questions off of it going forward. So I'd like to now introduce Helen Craney. Helen's a senior paediatric physiotherapist in the long-term ventilation team at Evelina Children's Hospital. She works with inpatients and outpatients and is the lead respiratory physio for children on home ventilation and children that have neuromuscular conditions. So over to you for a couple of minutes, Helen, just to add some key points, please.
Thank you so much. It's so lovely to be here, and thank you for inviting me to kind of to speak a little bit about respiratory physio. So we work incredibly closely with the neuromuscular team, with Vasantha and with Jennie. And I work as an integral part in the team to help our Duchenne's, children with Duchenne's as well as other neuromuscular conditions, really have the best quality of life. So I kind of wear two hats, I always say. I have a ventilation hat where I work really closely with our CNSs and our respiratory consultants to help identify and get children on ventilation when the time is right. And also my other major role is to help manage children that are having recurrent chest infections, usually because they have lost their cough strength. So keeping an eye on what's going on and providing cough augmentation or kind of equipment or techniques to help if children are struggling, or young adults, obviously. Yeah, that's a bit about what I do.
Thank you, Helen. I'm just going to jump around a little with the notes I do have and come to Dr. Phil Davies now, because it seems more relevant following Helen. So an introduction to Dr. Davies. Thank you for joining us today. He's a consultant in paediatric respiratory medicine in the Royal Hospital for Children in Glasgow. He trained in Cambridge, Manchester and Cardiff before moving to Glasgow in 2008 as a consultant. His clinical interests include children on long-term ventilation, sleep medicine and children with neuromuscular disorders. He runs a regular multidisciplinary neurorespiratory clinic that manages children with neuromuscular disorders from throughout the west of Scotland. So over to you, Dr. Davies, just to make a few comments.
Thank you for inviting me. And yes, I work with people like Helen up in Scotland, in a very similar kind of role, really. And I suppose the idea of people with respiratory being involved in children with Duchenne is something which, to some extent, we have to introduce patients and families to quite early on, because everybody thinks about people's muscles and arms and legs not moving so well. But actually, breathing is a really muscle-driven activity, and often one of the areas where children and young people can have problems. And it's one of those areas which is important to think about and to monitor. And it can go a little bit under the radar. So I start getting involved in a quite a regular way when people start becoming non-ambulant, but often even earlier than that. Sometimes I'll start an earlier conversation. And to try to sort of, and our job really is to try to prevent complications. And it's an area which really, as I see it, there are two main areas which we try to think about. One is to make sure that children are appropriate to prevent chest infections, really, because chest infections can be rapid, progressive, and sudden and devastating. And so we need to be able to get in there early to know how to manage those and to help families know what to do. And then the other side is to try to work out when children need support with their breathing at nighttime. We all breathe less well at nighttime, and so more subtle things start to come out earlier at nighttime. So we start thinking about how and when to think about areas like ventilation, for example, which we know people do better if it's started at the right time. So broadly speaking, in terms of the infections, we start thinking about things like when assessments of strength of cough, for example. We look for history of respiratory infections. And even very early on, I will say to families that getting things like flu vaccination is going to be important, which will be by injection if they're on steroids, for example. So having those things even early on, and then advocating early treatment with antibiotics, for example, even frankly, if it's probably going to be a virus and they end up getting a few extra courses, well, so be it. And then starting to think about things like chest physiotherapy and different techniques that might be appropriate. So, for example, we use a lot of ambu-bags, for example, in treatments. Then other sort of equipment can come on, slightly fancier equipment, and things like cough assist machines may be relevant. And you're really guided by how far you go upon certain things clinically about how strong you think a cough might be, whether people are having lots of chest infections. And even things like peak cough flow and things are sometimes used as well to make decisions about what people do. So there's decisions around how we manage that. So treat early, sometimes even treat a bit longer than you might do, and then get help appropriately and early if necessary. And sometimes that involves coming into hospital. And so we start looking for things like that. And then we starting to monitor and do things like pulmonary function tests, blowing tests, looking at see, for example, when forced vital capacity starts to dip, say less than say 60%, we might start doing more detailed sleep studies. And that might be measurements of oxygen, carbon dioxide, which or even more detailed sleep studies to decide when the right time is to start ventilation. I think even in my careers, things like steroids and more active intervention with things like scoliosis surgery has come on. There are fewer people actually needing to start these in paediatric life, and often it's more in adult life. But we get surprised sometimes and find ourselves needing to do things earlier. And as I say, we know people do better if we intervene early. So those are the kind of roles that I work with colleagues like physiotherapists like Helen to try to manage the young people with Duchenne.
Thank you, Dr. Davies. And there was a comment in the Q&A about recording. Just to reiterate, we are recording the session and it will be available a week or so after the seminar. So now if I can move, I will come to the set questions soon, but I'd like to just finish introducing the panel for the time being. So now if I can come to Jennie Sheehan. Jennie, thank you for joining us today. Jennie is a clinical specialist paediatric physiotherapist at Evelina London Children's Hospital. She has over 30 years experience in working with neuromuscular disorders, mostly in paediatrics and some adult M&D work also. Jennie is involved in teaching and service development and was one of the developers and authors of the North Star Functional Assessment for DMD, which is now well recognized and used worldwide as the gold standard in DMD assessment. So over to you, Jennie, to make a few remarks, please.
Hello, thank you, Nero. Yes, so I also work at Evelina. I'm clinical lead for the physio side for neuromuscular, and my role is sort of twofold, really. One is that we do standardized outcome measures such as the North Star and other measures as well, and then we input that to the national database, the North Star database. And the importance of that is so that people can look at trends of what's happening at what age, and so we can all share data and learn from that. So that's a very important part of our assessment. But the other part of that, which probably is more important, is the individual side of that and looking at a particular child's problems. So if they have asymmetrical muscle power, how are we going to deal with that? Looking at contractures, prescribing orthoses, they might be night splints, it might be a spinal brace in teenage years. So recognizing if a child is losing ambulation and whether they might be suitable for rehabilitation in CAFOs. So it might be referral to orthopedics. So we're doing the bit that everybody does and the standardized assessments, but then we need to look at how is that useful for that child and that family, and how are we going to help manage them on a day-to-day basis. I also then I'm in contact with the community physios. The community physios are great. They're very understaffed, and they might actually only have one child with Duchenne on their caseload. So they do need some guidance in what to do and what we would suggest. So we're in contact with them all the time to give them advice. And obviously we're in contact with the family. We advise on exercise. What we want most of the children to do is do what they want to do, to be honest. Join in with PE and do normal activities. The one thing that they should avoid is trampolining because of the way the muscles work in an eccentric fashion. But otherwise, we're trying to encourage them to do what they want to do in life. And sometimes that might be things like suggesting a wheelchair a little earlier than families might have considered, because you're going on a day out or a school trip and you can use the wheelchair to get from A to B and then get out and enjoy the activity and enjoy the exercise that way. So there's a lot of things involved. Thank you.
Thank you, Jenny. That's been really, really helpful. So I'd now like to, last but not least, introduce our final panel member. So Gerry McMenemey. Gerry and his wife, Sarah, are proud parents to 10-year-old Sawley, who was diagnosed with DMD when he was 3.5. Gerry has been associated with MD UK since shortly after Sawley's diagnosis through their family fund. Muscle in with Sawley, MD UK Scottish Council, and most recently through his appointment as a trustee for MD UK. Gerry's focus continues now on advocacy and campaigning for his son and others living with muscle wasting conditions to live full, rich and barrier-free lifestyles without exclusion, missed opportunities, red tape or discrimination. So over to you, Gerry, just to share some points in your story.
Well, thank you very much. Heard a lot from the clinical professionals and clinicians, but when it really comes to the closest person that's going to be to your son, your child with Duchenne muscular dystrophy is you as a parent, and that's something that we find never to look too far away from, because you're going to be the person, the awkward, difficult questions, the frustrations, either directed at you or from you, you'll come from. So what we have found that we had to do very quickly is, first of all, you've got to understand all these ologists that are around the table and who to ask for assistance in which particular time. Peer support, other families reaching out and sharing your story, asking how they have managed something like that is absolutely invaluable. And very quickly realise that you mentioned advocacy. You are the most central advocate for your child. Nobody else is going to come along and coordinate everything for you. It doesn't happen. The clinical side, yes, it can be very coordinated, but as soon as you start to look at education, adaptations at home, transport, vehicles, statutory responsibilities of social work, you have to do that and you have to learn. It's a very, very fast learning curve to get there. But the one thing I would say to every other parent of a child with Duchenne is that have the confidence that you do become very well educated and almost a subject area expert on how to coordinate everything that your child should be getting.
Thank you, Gerry, for sharing your expertise. And it's always good to get a parent's perspective because you are living through the condition. And it's been great today to meet you all as a panel, and it just shows the breadth of speciality that's involved when supporting someone to live well with DMD. So I do have some questions in the Q&A, and we've got some pre-questions as well. So what I will do now is try and go through a few questions. And like I say, anything that we haven't answered, we will come to after the webinar. So while we were talking about respiratory care, we did have a question in relating to that. So the question is there anything parents can do to help retain some cough strength from early years, preschool age? So that's over to both of you, Dr. Davies and Helen.
I can talk vaguely. I mean, muscles of breathing are muscles, and to some extent, the treatments that people are using in terms of things like steroid treatments and things in terms of maximizing their muscle strength in general are very pertinent to the actual respiratory muscle strength more broadly. And obviously, we've heard things about clinical trials today as well in terms of going forward. So there are aspects as well. I think things like scoliosis, for example, can start to seriously impair upon the strength of cough, for instance. And so there are aspects of scoliosis surgery, trying to keep good seating postures, trying to actually, or braces and things to try and prevent scoliosis getting worse is quite important. Flip side, I think we also need to be careful that very restrictive sort of jackets and things like that, for spinal jackets, can also impair that. I think that it's more about how we manage the cough going forward in terms of making sure that people can take those deep breaths. So you need to be able to have good, strong coughs. But I don't think there are specific kind of respiratory muscle strengthening exercises or cough practicing things that really make a huge difference in this sense. I think it's more that broad how we manage to sort of support a cough that is there, and more broadly how we manage all muscles really, because I think respiratory muscle as a skeletal muscle is very similar to the rest of the muscle system. And again, things like good nutrition, all these things feed into muscle strength as well. So there's lots of those things. So it's a more of a generalized sort of how we keep people well, I think, rather than specifically cough exercises, for example. Helen, is that your experience?
Yeah, definitely. I would definitely echo that. I think there has been some thought amongst respiratory clinicians that perhaps some of the devices, such as the lung volume recruitment bag, might help to possibly help over a longer period with maintaining how big a breath in that you can do, but actually the research doesn't show that from the limited research that we do have. So just wanted to mention that. What we usually say is we want our young people to be as active as possible for as long as possible. So we encourage them to be, I normally say, do everything that Jennie has suggested. So to kind of follow any kind of physio programs that you've got, and just to be as active as possible, doing as many different things as possible. Really good question though.
Thank you, Helen and Dr. Davies. So I'm just going to go to one of our advanced questions that came in, because you've mentioned scoliosis. It related to that and postural management. So just a question possibly for Jennie and Helen. What advice can you offer about postural management for a child living with DMD? And then the other part of the question was, how would this be monitored in a more long-term period, or short-term if there's short-term needs?
Definitely a question for Jennie.
Okay, so it depends rather a lot on the age of the child. So the most important thing for keeping a good spinal posture is actually walking and keeping mobility in the spine. And there is evidence that walking for a longer period delays the onset of scoliosis. So that is something that we would want right from the beginning. Swimming is also a really excellent exercise for maintaining mobility in the spine. As boy is starting to walk less and sit more, it's really important to have a good sitting posture. And that starts with a very basic, in a wheelchair, of sitting with feet, knees and hips all at 90 degrees and with a straight back. I hate it when you see the wheelchairs with a soft back, soft rounded back that encourages a forward, shoulders forwards and a kyphotic posture. So it's really important to have a good seating posture. One possibility, but tends not to work all that well usually in Duchenne, is sleep systems. And they were really designed for children with cerebral palsy. Occasionally they seem to benefit in Duchenne, but the problem with that is you're fixed in quite a set position. And then that's the balance of wanting to be able to move. And if you can move, we want you to be able to move. It also then has to tie in perhaps later on with what position you have to be in if you're on nocturnal ventilation, for example. So what we look at always is spinal posture in sitting and spinal posture in standing and spinal posture walking. And if you are, and also the flexibility of the spine. So if you're looking a little bit asymmetrical in sitting, but it's flexible, we might consider bracing. We tend to refer to the spinal team early, and that sometimes makes people worried that we're thinking about spinal surgery, but that's not the case. The spinal team want to monitor the progression, or no progression. If there's no progression, they need to see a child over time. So not everywhere, but certainly at Evelina, we can prescribe the bracing ourselves. So we will do that if we have concerns. They don't have to wait to see the spinal team for that. And then that is monitored with X-rays. And ideally that would be an X-ray in and out of the brace if bracing is what we're doing.
Thanks, Jenny. That's really detailed and really helpful. So thank you for that. Gerry, we did have a question, and you mentioned this in your short talk about peer support. So in terms of peer support, someone has said they'd really like to access peer support and speak to other parents who are in similar situations. How would they, what's the best way to go about gaining that sort of support?
There's a number of ways, and some of them you go looking for, some of them are happenstance and you bump into people. First of all, one that we found really helpful was coming along to the conferences that charities such as MD UK and other Duchenne focused charities have, around the country, and whether they be local or national events. And they're a really good introduction to meet other families, and actually the physicality of that really gives you a wee bit of cuddle that you're not on your own, and that there are other people going this, and these tend to at these events you'll find out a bit more about a forum, whether it's a Facebook forum. There's a number of WhatsApp groups. I am a member of a couple of WhatsApp groups. There's one that's WhatsApp group, and it's just dads. There's one with just mums. There's one with parents, and these can be quite helpful as well. And it's almost anonymized how you're asking the questions, and there are no silly questions. You think you're asking a silly question, but actually every one of us have probably asked the same one, and of course just actually going through the MD UK website, you'll see that there are some signposting for peer support. It's not for everybody straight away, very on after diagnosis, because there's a lot to come to terms with immediately after diagnosis. And it can be a bit daunting and overwhelming to chat with parents who are maybe 5 years ahead on the journey of where you are. And sometimes it can be a case of, how am I going to manage that? Well, actually, you will. You just do it, it happens. And there's a lot of people around about there through that kind of peer support that will help you. And it can be that either you just have that kind of online social media contact with people, or you meet up even through, for example, Sorley plays per-chair football, and there are a number of other young people with different conditions and also similar conditions who play, and you chat with the families, you share stories about your housing adaptation, how did you manage to achieve this, what's the best kind of wheelchair accessible vehicle to look for at the moment. So it's all that kind of practical thing, and the emotional support actually just sits there underneath it as well. So without actually having to look specifically for that emotional, because it's not just the wee one that needs that emotional support, it's the whole family. It's a lot to deal with, and don't be frightened to ask.
Thank you, Gerry, for raising some really key positive points and some concerns that people may have. I think Helen may want to come in.
I was just going to say that some families will ask our teams, and I'm sure everyone has had experience of this, of anyone that they can talk to within the same services. So then clinicians can kind of get a gauge at what sort of questions you might have, and, you know, families that have gone through similar, because obviously everyone's individuals as well as having similar kind of questions. So definitely you could speak to your teams as well about that.
Thank you, Helen. Really, really helpful. So yeah, just as I was saying about some of the points that Gerry made, the point about it's not for everyone, it isn't for everyone. I think you'll know when you're at a stage where you need that support, and it might not be at that newly diagnosed stage. There might be too much happening then. It might be at a later stage, a transition stage. So whenever you do come to that point, do contact us on through our website or our helpline, because we have also got trained peer support volunteers, and some of them are parents with children with either DMD or similar conditions. So do always get in touch with us as well. Definitely. And then the other key point about emotional support, I think everything that anyone asks for, however practical it is, it adds to that emotional support side of things that sometimes people don't realize they need, and it's for the whole family, definitely. So thank you, Gerry. So if we can now just step back to a couple more questions that we had in the chat. So I think we've got one here for you, Agnes. So the question is, how common is dyspragia, sorry if I pronounced that incorrectly, in the DMD population? Are swallowing AX with speech and language therapy offered in centres as a matter of course to gather baselines? And also, do speech and language get involved in things like communication? So quite a couple of questions there, really.
Of course, it would be really lovely to have a speech and language therapy colleague with us on the call, because I guess they would be able to answer that question. I'll try as best as I can. Overall, I don't have numbers when it comes to how common is dysphagia in patients. I don't know. From my experience, I don't see that often. Bear in mind, though, that we see children. We quite often see young children, and it might be that it will happen at a later stage, possibly. There are no kind of screening appointments with speech and language at Great Ormond Street, at least. But what I do as a dietitian, whenever I talk to patients with DMD, I always kind of have those screening questions as well in my assessment. So I do ask you know, about this, well, I do ask, or is your child maybe gagging, coughing a lot when eating meals? How long does the meal take? Is it, you know, less than half an hour, more than half an hour? I know that your clinician will definitely ask you about any respiratory infections, and then Helen and Dr. Davies probably will be able to elaborate on that. But is there any maybe silent aspiration or anything like that going on? So I think it's more of screening the patients because they're seeing so many clinicians already. So there's no point in adding a speech and language just for the sake of it, if that makes sense, because we'll be able to pick that anyway. And then, of course, if there's any problem, any issue, or if I would be unsure about something, if something would kind of sound not right to me, I would definitely refer to our speech and language, and then they would be able to see the patient or do a video call with the patient. And again, with communication, the same. I don't really see SLTs being involved at our center, but of course, if I would refer, they would be able to help with that.
Thank you, and sorry for putting you on the spot with speech and language, but thank you for your answer. Dr. Gowda, I was going to come to you as well, actually, and you've already got your hand up, so you read my mind. Over to you.
I just wanted to comment on the communication side of things and behavioral difficulties in general. It gets overlooked to some extent compared to the physical side of it, but anyone who has autism or significant behavioral difficulties, or children with either of those, will tell you that they are quite pervasive and influence daily life much more than, say, for example, the use of wheelchair or any other aspect. And in DMD, there could be absolutely no behavioral difficulties to bond or autism and everything that lies in between. In many patches of every county, the support or even the access to formal assessment has not been very good. There are only a few areas that can, sort of where families can access this easily and get the support they need. And this needs a full team. They need the community pediatrics with the SALT support for the communication. And in more severe behavioral difficulties or communication difficulties or autism, the full CAMS team. We all know that the waiting list in many patches is 2 years, 3 years even. It's only a lucky few which have less than 1 year. So this is something that hopefully people will address and keep raising until this is gets the attention and the solutions it needs.
Thank you, Dr. Gowda. Dr. Davies?
Thanks. Yes, I mean, just my experience really around speech and language therapy. I mean, I agree it's not part of the standard sort of team, if you like, but we do have access if we need to these services. The concerns, I suppose, would be ones that if people's swallow became weaker and weaker, that actually they wouldn't be able to safely swallow. And you can have issues, for example, with choking on food, for example, which is something which could present. So you could have respiratory infections because food goes down the wrong way. There could be issues associated with silent aspiration as food slowly goes down the wrong way until people realize. In pediatrics, I must say, it's quite an unusual thing in general. I think as people maybe get much weaker and as people live longer and longer into adult life, then obviously other muscle groups can start to be affected. I suspect that may be where it shows itself. We don't see too much of that. But again, you'd access accordingly and do investigations at that time. In terms of, often I thought people, in terms of the time it takes people to swallow, I think is part of the thing. And I think that's probably where the whole dietitian side of things is as well, that if people basically are spending so long eating because the chewing process is taking at that, then it may well be that we find ourselves in a situation where, for example, supplemental feeding is needed, not necessarily because the swallow is unsafe, but to sort of not, that this doesn't become the whole life, if you like, taking over. And I think in that sense, it can be used as part of the enjoyment, if you like, of assessment around that. The other thing I actually didn't comment on before, often about weight loss going down, sometimes that can also be a sign of people not really breathing very well. And I've heard the expression used before about feed them air, because essentially once the breathing starts becoming a problem, that can be one of the times when the weight starts going down. In terms of communication, I mean, there are people on the autistic spectrum, for example, which can go along with Duchenne. In general, though, people who are able to talk, in general, they going into adult life, they continue to be able to talk and communicate in a sort of pretty standard kind of way. So again, it hasn't necessarily been needed, from my experience at least, certainly not within paediatrics or going into, but I can see how if you were to go into adult services and if you had more advanced forms of ventilation, I suppose that could be a thing. But in general, most people with Duchenne who can talk are able to continue to do that. So the communication in general isn't a problem for most children or young people.
Thank you, Dr. Davies. Agnes, you've got your hand up as well.
Yeah, just wanted to add, because Dr. Davies mentioned, gastrostomy feeding, and I think it's just so important to discuss that with families early on, because as Dr. Davies said, it is that sometimes, eating overtakes your whole life. So remember that, having gastrostomy might be just a safety net. It doesn't mean that your child will not eat from now on and everything will need to go down the tube, but it is just there for you to have an option and for your child to have an option and say, today I don't feel like chewing the food for an hour. Can you please give me the formula and tomorrow I'll enjoy my food. So remember, it is just a safety option for you to have, and maybe for the times when they're unwell and they just need some support with that.
Thank you, Agnes, and thank you all the panel that have commented on that question. I'm now going to leave you.
Is it okay to jump in with one more thing, if that's okay?
Of course.
I was just going to add as well that we have seen some of our young adults recently with Duchenne's that have undergone surgery, say if they've undergone some scoliosis surgery, for example, and we have noticed that sometimes that their eating and drinking and swallowing has changed over that period of time, because it's such a big process to go through kind of perioperatively. So just to add that in as another kind of point in time just to watch out for.
Thank you, Helen. That's really, really helpful. So I am going to have to leave the seminar for now, but I'm going to hand you over to my most capable colleague, Jackie, who will just complete the rest of the seminar. I think we've got a question in the Q&A and a couple of other pre ones. So I will hand over to Jackie. Thank you, everyone.
Thanks, Nina. So we do just have another few questions to go through. So Dr. Davies and Helen, this might be one for yourselves. So someone has asked, at what stage might their child living with DMD need to have non-invasive ventilation, and would there be any kind of signs or symptoms around that? So I'm not sure if there's a particular age range where that might be, where that might happen, and if there's anything that might go along with that as well.
Yeah, there aren't that many papers around this actually about when the right time is, but there's perhaps some evidence that maybe going in too early is at least not beneficial and possibly problematic. So trying to find the right time is part of what we do, I suppose. I suppose the things we start to look for is when, for example, lung function starts to dip, particularly things like forced vital capacity. But that would then trigger us to start looking for usually more detailed sleep investigations. And usually it's when you start seeing signs, for example, of carbon dioxide starting to rise at night time. That's the only real evidence that suggests it's the right time to start on ventilation in general. So that in terms of sleep studies, but other things will feed into that conversation. You will look to see whether, for example, there's a rapid decline in trajectory of how people are doing. If perhaps people are having lots of respiratory infections, for example, NIV can be quite useful, almost as a form of chest physiotherapy in its own right, actually, as well as actually just supporting nighttime breathing. There may be specific events in terms of if someone's going through scoliosis surgery, for example, then sometimes that can be a very helpful adjunct to help them get through that surgery well. And then on top of that, so and in answer to the question about symptoms, it's often quite hard because I think quite often it's something which people don't have symptoms, and they're going through a phase where the muscles are perhaps getting weaker and they're not able to do as much, and they do feel tireder. And often it's put down to that kind of feeling or it may just be completely asymptomatic. And so it's one of those things where we're certainly not just waiting for symptoms, but if somebody was having symptoms, that might also influence it too. And the other thing which I think I've also been caught out of was we're really trying to think about ventilation in terms of treating people who are essentially not taking deep enough breaths, we call hypoventilation. But we also see the non-invasive ventilation being used, for example, in children who have things like obstructive sleep apnea, which we see in lots of other conditions, and particularly in some of these phases where perhaps people's weight has gone up a bit, for example, that can be a stage when it may be useful for that kind of treatment too. Again, the muscles are not quite perhaps as well toned as in the upper airway as well. So there's a variety of things that can guide you in there. And really, I suppose what I'd say is that it differs from person to person. It differs just as muscle strength, it differs from person to person. The breathing muscle strength differs from person to person, which I would say why people like me are involved and should be involved in your clinic in terms of monitoring this in a regular way, to have the conversation, both in terms of lung function, in terms of sleep, in terms of clinical assessment, to make sure that we're going in at the right time, because it is a bit of an art to try to work out when that time is, and that's part of the conversation, which is why, I suppose, why we're involved in the clinical assessment all the time.
Thank you.
And then I guess we would normally ask about sleep, both from a physio and from a respiratory medicine side of things. I ask it in all of my clinic appointments. So some things that we might ask and we're looking for is we'll ask you what time is bedtime, how quickly do you fall asleep, or do your child fall asleep? We'll ask whether there's any snoring or you notice any pausing in breathing. If there might be some children or young adults who wake up with a headache in the morning, or that normally like to have breakfast in the morning but feel a bit sick or don't want to have breakfast in the morning, and whether maybe they have some falling asleep during the daytime when they don't normally. So I'm sure Dr. Davies, you would ask exactly some of those questions as well. But some of the things that the symptoms don't always match. When we do a sleep study, they don't always correlate. So, but those would be some of the things that we would ask.
Thanks, Helen. There's actually another question that's just come in, Helen, that might be for yourself. So somebody's asked, is it beneficial to start prophylactic chest physiotherapy?
Oh, that's a really good question. So we always want to do chest physio for a reason. So, we're looking to see if there's any, what we would call kind of chest physio problems, similar to Jennie. So we're really, in our patients with neuromuscular disease, as everyone's been mentioning, are thinking about muscle strength and taking a big deep breath in. So in some other conditions that aren't neuromuscular, we would, some conditions such as cystic fibrosis that are not maybe responding to treatment. Lots of those children would do prophylactic chest physio just to help, which would include some manual techniques to help kind of shift and move everything, because we know their underlying disease means that stuff gets a bit stuck. But we tend to really only want to start to give chest physio when there's an issue that we've identified, I would say. And again, I would ask Dr. Davies about this as well, but we would normally maybe introduce some techniques if we saw that a child was starting to maybe not breathe as deeply and their cough strength was starting to kind of reduce a bit, but it wasn't yet a problem. So I mentioned something called the lung volume recruitment bag, or AMBU bag, and we might use it prophylactically to get the child used to using it, so that when they do need to use it, and it's important to be able to use it, then they're used to it, and it's not kind of a big deal to add that into a sort of stressful situation.
Yeah, I'd agree with that completely. And there's the idea of you needing it because you're ill, and there's definitely an increase in need for it when someone's actively ill. And there may be a time coming when using it on a more regular basis is important. Usually you're in a situation at the start, though, where you don't want to suddenly be caught short when someone gets a chest infection and suddenly they have more secretions, they're much weaker than their baseline would be. And suddenly you're playing catch up trying to introduce physiotherapy at that moment. What you want to have is a situation whereby when you start having some concerns about the chest, or the cough is not so strong, or they're not taking, or their lung function starting to dip, that they have the techniques available to them. And that's not necessarily to say that they need to be able to do it every single day, but sometimes it's quite useful to do it in a reasonably regular way, so that suddenly people feel familiar with it, at least, so that suddenly when you're ill, you're not starting to try and which way, what connects onto what. And so, and it's dug out of the cupboard and covered in dust, and that's never a great starting point. So I think that doing it regularly, not because you necessarily need it, but because you know how to use it should it become unwell. And then once, and so the advice then would be, that's fine, you know how to do it, keep that technique up to speed, but then increase that at times of respiratory infections. And similarly, then you may get to a stage when actually you don't have those deep breaths. And so actually, in the sense of using it even though you're well, is something which a point you may well get to, because it enables you to take those deep breaths in to stop secretions building up. And then because you can take that deep breath in, essentially you can fire the gun, really, which is your big cough, if you like, with that deep breath, in a way which, if you're not able to have that deep breath, then you wouldn't do it. So you might not be ill, but you can still be using it in a regular way, but again, increasing that more if you do have more secretions. Sounds like we're doing the same thing, Helen.
Yeah, exactly. And I think as well, you know, when you or maybe your child gets to the point where they are having slightly shallower breath in the daytime as well as the nighttime, then actually it's kind of prophylactic, but I see it more as a maintenance as well. And I often say to some of our children and our families that, you know, we're giving kind of stretches and advice from, like, you know, a limb point of view and a moving point of view, but it's always good to think about the rib cage as well. So, you know, the rib cage, if you're not taking big breaths, then it is nice to, you know, get a big breath. And most of our children and young people, they do like the feeling of doing chest physio. If it is kind of, you know, big deep breath related, it makes them feel nice. If you think about doing yoga and you're doing your nice breathing, you know, kind of it stimulates your parasympathetic nervous system, so it can be nice from that side of things as well.
Thank you. Thanks both. So that, I think that takes us quite nicely on to the next question. And Jennie and Helen, again, this might be for you too. So someone has asked, what should local access to local physiotherapy look like at a local level? And I suppose there's different parts to that, because there'll be kind of community-based physiotherapy, respiratory physiotherapy, and then the neuromuscular physiotherapy as well. So Jennie, I don't know if you maybe want to come in first and answer that question.
Yeah. So all you can really expect, to be honest, in the community is community paediatric physiotherapy. Once you transition into adults, that's a whole different ball game. Unfortunately, there are not enough community paediatric physios, and they have huge caseloads. And it is unfortunately a bit of a postcode lottery as to how often your child is seen. In some areas it might be monthly, in some areas it might be twice a year. So the emphasis, the community physio's emphasis has to be on showing you what to do and encouraging the parents and the children with a programme at home, and then being available to answer questions, as are we in the tertiary centre. The other side of that, sorry, just gone out of my head what I was going to say then. So it's very difficult. We get a lot of people coming and saying we're not getting enough physiotherapy, or we're not getting enough hands-on physiotherapy. But if they're only seeing your child for 2 or 3 times a year, they've got to focus on, this is what you need to do, and also focus on what equipment you might need. And part of their role is to provide that. And part of their role is also to be involved with the EHCP, so to perhaps show teaching assistant how to do the stretching at school and take the pressure off parents at home. So everybody always says they don't get enough physiotherapy, and that's on the muscle side. On the respiratory side and the adult side is even more limited, unfortunately, but I'll let Helen pick up on the respiratory side.
Thanks.
Yeah, so thank you so much, Jennie. So we would normally, from a tertiary point of view, I would always see the patients normally first with the respiratory consultant. I don't know, again, Dr. Davis, what your setup is, but physio-wise, we like to do a joint first assessment when the patient is referred into the respiratory team, and then we can kind of work out where we're going to go with respiratory care. Now, there's limited pediatric physios in the community. There's even more limited respiratory physios, and I think this is one of our biggest challenges overall in respiratory physio care in the UK, actually. So from a tertiary centre point of view, we again will see children and young people, often with the consultant. Sometimes we will see them separate in clinic as well, in between the consultant appointments. Sometimes we'll see the children on the wards as well if they need a touch base if something's changed. But I would say each kid is a bit individual with what they need. So again, sorry to the families, but we are teaching and getting you to do everything at home. I know that's a massive burden. And actually, for me, that's why kind of when we're thinking about prophylactic physio, I'm always thinking, is this going to make a difference? And, is this adding to the child's life, doing physio program on a day-to-day basis? Have they got the hang of it? Can we just do it when they're unwell? I think previously the thought had been, no, it's really good. We should be doing it every single day, but the research doesn't always support that. So then as it's such a big burden of care, do we say, okay, well, it would be great if you could just do it once a day, just do a couple of rounds of either, whatever program you've got, whether it might be, the lung volume recruitment bag or a cough assist if you're using that. So it would be quite individual, I would say.
Thanks, Helen. And I think that just takes us on to our last question. So, Jennie, I think this last question's for yourself. I think you'd mentioned trampolines earlier. So someone has put a question in the chat to say, should large trampolines be avoided, and that they were kind of given advice at small trampolines. So I'm assuming the really mini ones were kind of recommended to them as well. So just, I suppose, anything around the trampolines and whether they should be avoided.
Okay. It's not really about the size of the trampoline, it's about the muscle work. And the way muscles work when you're trampolining is that they are working by getting longer rather than getting shorter. And there's evidence that this eccentric muscle work can cause muscle damage. So my advice is always to not have a trampoline at home. But if your child's going to a birthday party and there's a bouncy castle, it's not the end of the world if they go on the bouncy castle for 10 or 15 minutes. We don't want to spoil anybody's fun, but if you've got a trampoline at home, then it is going to be used a lot. So that would be my advice. I think all I can think of in terms of a small trampoline, they might be thinking that if it's the thought that you hold on, that you're not using your muscles quite as much, you're using your upper limbs a little bit more. But my advice would still be to avoid trampolining, apart from, the odd few minutes if you're at a party or a special occasion.
Thanks very much, Jennie. So unfortunately, that's brought us to the end of today's session. So I'd just really like to say a huge thank you to all our panellists and the people who helped to guide the discussions today. Really good questions and comments. So as Neera mentioned earlier, you can see the recordings of all our seminar sessions on our website, and the recording of this session will be posted there later this week. And we'll also be in touch with people who attended with a very short survey just to gather some feedback on the session, which is invaluable to us in how we shape the seminars going forward in the future. So just a reminder, our virtual information seminars are a source of information but shouldn't replace direct advice from your own specialist consultant or healthcare professionals. If you do have any concerns, you're advised to speak with your neuromuscular clinical team or health professionals directly. Thanks again for joining us, and a huge thank you to the panel for their time today. Thanks, everyone.
Thanks.